Good evening. I'm Dr. Jeffrey Spear, current president of the El Paso County Medical Society for 2022. We at the El Paso County Medical Society are very proud of this program. We are certainly grateful for the collaboration of both Star City Studios and KCOS for making this program a reality. We're also incredibly grateful to Ms. Catherine Berg, who has been such a terrific partner for the last 25 years being this program's host. We hope you continue to join us each and every month for this fantastic program, and please enjoy the presentation tonight. Thank you very much.
Good evening. Welcome to the El Paso Physician. This evening, we're going to be talking about pregnancies, but we're going to talk about some pregnancies that don't always go so smoothly. We're also going to talk about special deliveries. We're going to talk about a plethora of other issues that mothers face as they are pregnant and things that may happen during pregnancy and or when there is an unexpected birth that happens a little bit too soon. We have two doctors with us this evening that are here with Tenet and Hospitals of Providence. And we also want to thank very much the El Paso County Medical Society because they've been sponsoring the show for you for 25 years. I'm Catherine Berg, and you're watching and listening to the El Paso Physician. Thank you again for joining us. I'm Catherine Berg, and this is the El Paso Physician. Tonight's title of the program is What a Level 4 NICU and Maternal Care Designation Means to Expectant Mothers Here in El Paso. We have two specialists with us this evening. We have Dr. Maria Velasquez, who is maternal fetal medicine at Hospitals of Providence Memorial Campus. And then we also have Gregory Welsh with us, who is a neonatologist at the Memorial Campus of Hospitals of Providence. So we have a lot to talk about because there are things going on that you take care of the mom before baby is born, and then sometimes there are some issues you know about ahead of time, and then sometimes there are issues that you don't know about ahead of time. And Dr. Welsh, you deal with that after the baby's born. It was kind of cute because Dr. Velasquez was saying, well, I deal with the baby or deal with the moms, and then once the babies are gone, I hand it all off.
That's correct.
But I think that there's a lot of follow-up and teamwork that goes along with this, so I'm super curious about that. And Dr. Velasquez, I'd like to start with you because maternal fetal medicine, that's not something you hear all the time. You hear OBGYN, you see, obstetrics doctor.
Yes, so all day long I deal with mamas that have complications such as diabetes, hypertension, heart disease, something medically complicated with the mama, or a pregnancy that's complicated with the fetus, either abnormalities or growth restrictions, something that's going to require an intensive following so that we can have the best outcome for the mother and the baby.
Okay. And so you are partnering then with the mother's OB that may have been like from the beginning her doctor. And is there a certain point where there's a handoff and or now we have to call Dr. Velasquez? What's happening here? When does that usually happen from an OB to then your specialty? Is that something that happens midterm or is it as the OB finds that something's wrong?
So the interesting thing is the ideal is to identify the issues before the mother gets pregnant. And sometimes they refer them to me for preconception counseling. And that's always good because then I can follow them when they do become pregnant. And then if that doesn't happen, because not everybody seeks preconception counseling,
right,
then I see the patient as soon as the primary obstetrician identifies the problem either with the mother or the baby.
Okay, I really want to talk about that when we get back. So I'm going to introduce Dr. Welsh here, but I'd love to talk about what it is that could be an issue prior to somebody getting pregnant. I think that we don't really talk about that space very often. So
Correct.
I think tonight would be a nice way to do that. Dr. Welsh, neonatologist, I know that everybody thinks, oh, well, it's when the baby's a preemie, but it's not always necessarily that. Oftentimes it is. But how would you describe what you do all day, every day?
Well, first of all, a neonatologist is a pediatrician that then does 3 additional years of training taking care of critically ill or premature babies. So any baby that is born that requires more than just a normal newborn nursery being with their moms. So it could be low blood sugar, it could be some respiratory distress after birth, or it could be complex congenital anomalies that are identified by Dr. Velasquez or other maternal fetal medicine physicians that we take care of in the neonatal intensive care unit. So I spend my day solely, I don't have an office. I spend my day solely in the intensive care, in the neonatal intensive care unit, day in and day out. And we have a team of specialists there, myself or another neonatologist, neonatal nurse practitioner, occupational therapy, physical therapy, speech therapy, nutrition, on and on and on and on.
Yeah. What has become some advancements since 22 years ago to today? And I had just a plethora of it. Major, he was just saying, just tell them thank you. Tell them thank you for letting my baby live. On the idea, Dr. Velasquez, I would talk about when you said prior to conception, when people know, I really want to be a mom, I really want to have a baby, but these are my issues. What are some of the most common issues that might either prevent pregnancy or have a hard time conceiving? And then once conception happens, what are some of the things that you counsel to be moms, I guess? What would the term be? People who want to get pregnant, people who want to have babies that might have some issues.
Future moms, I guess.
Future moms. There you go. Future moms. I like that.
I guess one of the very overlooked issues that can cause a lot of problems is obesity.
Okay.
And people don't usually come to see me for obesity, but that leads to diabetes and leads to hypertension. So if we can achieve a normal weight, or at least closer to a normal weight before pregnancy, that is a better prognosis for the mother when she gets pregnant.
Okay.
We also see mamas that have recurrent losses. And so we try to identify what was the cause of the losses so that we can intervene and hopefully have a better outcome for the mother, either because of incompetent cervix or a coagulation disorder, a thrombophilia that caused the loss. Or maybe she's prone to having a baby with chromosomal abnormalities, and we can screen the mother and the father. And then also hypertensive disease, cardiac disease, just to make sure that they're even a candidate to be able to carry a pregnancy safely without too much risk for the mother.
So when you're talking about these pre-conditions, so to speak, how is it that you go through the testing? I mean, there's some I can see that if you've got chromosomal issues, that's maybe a blood test. But some of the screenings that you were talking about, how are those put together? For example, do you just clinical questionnaire, I'd imagine, to start with, and then from there, how do you commonly ask them, okay, I'd like to have a screening for A, B, C, and D? Like, how is that determined?
So it just depends on the history.
Okay.
Have they ever been pregnant? Have they tried to get pregnant and haven't been able to? Then that's more of an infertility workup, and we look at hormones. Have they lost the pregnancies? We try to identify, is it the uterus? So then we need imaging, either ultrasound or MRI. Have they lost the pregnancies in the second trimester because the cervix dilates without contractions? That's an incompetent cervix. So then we know that they need a cerclage placed when they're pregnant. Do they have a history of heart failure? Then we know we need an echo on the mama to make sure that she is even a candidate and that she'll be able to tolerate the increased volume and the stress that the pregnancy brings for the heart. So it just depends on the disease process that we're dealing with.
You know, it's interesting. I have two children, but I lost one in the middle. And it's always haunted me as what was it something I did? And I never knew what the situation was. I was almost at 3 months, so I was pretty far along. And then luckily I got pregnant again within 7 or 8 months, so I didn't research it. But if I had not gotten pregnant, I always thought, okay, what is it that, I never paid attention to it before I lost a child. And then when I lost a child, I thought, okay, what is it? Why did that happen? And the doctor said it just happens sometimes, you know. But that's why I'm curious too, as to how the screening comes about. Like you said, the history. And I never went into my history because luckily I got pregnant again and we were kind of done having children. But I love the idea that, and we'll probably touch base on that several times throughout today. Dr. Welsh, so I would like to put a scenario in there of when Dr. Velasquez says, you know what, we'll probably have a baby that is either born early or has some kind of an issue. And I'm assuming that's where the two of you kind of talk and discuss some things. And I'd love to, if you can come up with a case study or think of a case study without any names or anything, on maybe an issue that was happening, that mama was having, and then into the birth and then going into your hands. What might some of those common issues be?
Well, probably the most common is a mother who presents with preterm, what we call preterm premature rupture of membranes. And so that's when the mother's amniotic fluid ruptures. She starts leaking fluid. She may not know it at first. She may then she comes in and she gets evaluated by the obstetrical team, and they consult Dr. Velasquez because it could be a baby that's pre-viable. It could be a mother who's only 20 weeks. Currently, our level of, the earliest a baby can survive, and even that is, not a large percentile, but it's 22 weeks. And so we could have a mother that comes in at 21, 22, even 23 or more weeks that she's broke her water. And then the issue is from that point on, they stay in the hospital until they deliver.
Right.
And so we initially, Dr. Velasquez will get consulted. She'll evaluate the mother and what's going on, make her recommendations to the OB. The OBs will consult us to talk to the mom about, what happens if she delivers now, like if we can't stop her from delivering, or what's, going to happen with the baby. So we'll go in and we'll talk with the mom and kind of get a sense for, is this seem like it's going to be imminent, or this could be a mother that's going to stay in the hospital for 6 or 8 weeks or longer sometimes.
Stay in the hospital, but still carrying the child,
exactly.
So able to carry the child.
Because as long as the baby is healthy inside, even as great as the stuff that we can do now in the neonatal intensive care unit, it's still not as good as what the mom can do inside her womb. As long as all the other factors that Dr. Velasquez is checking on are okay. They do fetal assessments on the baby to make sure that everything's okay inside. And I tell the moms, when I go in there, I say, do everything they tell you. If they tell you to stand on your head, stand on your head.
Stand on your head,
If they tell you to, don't move or don't ever get out of the bed or whatever, because every day, never mind weeks, but every day makes a difference for the prognosis for the baby and survival and what we call neurodevelopmental disabilities, which the more premature you are, the higher the likelihood of those happening.
What might be some of the directions that you are giving mothers who are in a situation that Dr. Welsh was just talking about? They are now thankfully in the hospital. We know that things could go wrong and not so well if you didn't keep the baby a little bit longer. What are some of the precautions you ask them to do? Yes, they're in the hospital, but what are there medications that are being given? Obviously nutrition, exercising, what would that be? What does that look like?
So we actually do have them almost stand on their head. So we put them
only we had a
with the head
photograph of that.
down, with the head down.
Okay.
And that's more in the case where the membranes are intact, but they're coming out of the cervix, and we're trying to get them to reduce back into the uterus so that hopefully we can put a stitch in there and keep them from rupturing. And we give them magnesium sulfate. That has a two-part purpose. One is to help the contractions stop if they're contracting.
That's exactly
and the other one is for development, actually neuroprotective effect, so that he can get a better baby with a better prognosis. So it helps protect the baby's brain.
Okay. And how
so
does
that
it do
there's
that?
less injury. Well,
So
we
physiologically.
don't know, but their brain is very fragile, and for
Right.
some reason, we used to use it, and we still use it for contractions, and they noticed that when those babies were exposed to the magnesium, they had a much better prognosis and less severe injury to the brain. So, do you know?
So now it's used less,
Yes.
it's really used less for stopping contractions and more for
for the baby.
protecting
For
the
brain
baby's
development.
brain.
So protecting, is there anything, and I feel silly even asking this because I think the answer is no, but is there anything that helps facilitate the growth of the baby, and not in size, but the advancement of everything that's happening with the organs? Or is it literally just, like you said, it's mama, our biological systems have that happen, so it's just making sure the baby stays there, and then our magical systems do that?
Well, we give steroids to start
Okay.
maturing the baby's lungs.
Okay.
So, they work, for a period of about a month. The biggest benefit is within 7 days of administration, but we try to keep the mama pregnant at least for 48 hours, from the first dose so that the baby can get some benefit from it.
Okay.
And then if the month passes and she's still pregnant and we think that she's going to be at risk for delivery, then we'll repeat the course of steroids in order to stimulate the lung maturity some more.
Okay. And so, Dr. Welsh, actually, I'm gonna go backward a little bit because I remember the APGAR score. Am I saying that correct?
Yep.
Let's talk a little bit about that in association with, and we'll start at 22 weeks because I'd like to know what organs, and you specifically said lungs, what organs are specifically at most risk for the baby not to be viable, for the baby not to be able to live, if I'm going to put that in audience terms. So when we're looking at APGAR score and the baby's born at 22 weeks, are you looking at the same stuff you would look at when a baby is born full gestational time frame?
Not really. The APGAR score is a tool that was developed by Virginia APGAR and a long
Always kind of wondered where that name
yeah,
came from. Good to know.
Long time ago, and it's 5 different features of the baby, and each one is either 0, 1, or 2 points, and so a 10 is a perfect score, and it's become something the OBs they want to know right away what's the APGAR score. And because they like to put it in their notes in their chart, and that I have a 10 or a 9 or whatever,
But he never gives us a 10, so.
Nope.
No.
Back to your question though, as far as the very premature baby, honestly, we're busy doing, with a very premature baby, we're busy doing a lot of other things. And then it's only like afterwards we kind of go back and say, well, what do you think what was the APGAR score? It's like, because we're busy putting a breathing tube in the baby.
Exactly, doing the big stuff.
And maybe doing chest compressions or giving them medicine down into their lungs or stuff like that. And so the most vulnerable things for the most premature babies are their lungs and their brains and their intestines. Those are the other organs can certainly be, adversely affected as well, like the kidneys and the eyes and whatnot. But the ones that tend to lead to the baby not surviving is typically they either have severe respiratory distress syndrome, that they're not able to oxygenate and ventilate, so get oxygen in and carbon dioxide out, or they get what's called an intraventricular hemorrhage. So there's these little tiny blood vessels in the developing brain that are very fragile.
Right.
And so things such as a swing in the baby's blood pressure or getting a bolus of fluid or something too quickly, or moving the baby too much and things like that can lead to bleeding that goes into the ventricles of the brain, the center of the brain that's filled with cerebral spinal fluid. And that blood can actually cause not only damage to the brain, but also block the drainage of the spinal fluid and lead to hydrocephaly, or kind of enlargement of the brain filled with spinal fluid that's not able to drain throughout the whole spinal fluid system. So.
And we had a program specifically on that not quite a year ago. There were some craniofacial issues, but then it was just swelling on the baby, or what people call, I think, water on the brain. And I since you started in on that, I would like to continue that for a moment in people who may, either moms or grandparents or whoever might be watching the show, that there were several case studies that we talked about on that program where it seems like the head's swollen, but I'm not sure. As someone who's at home and you're looking at your baby and you're thinking, what is it that I'm looking for? Because once it gets too far, it's too far. And so that's kind of an odd question maybe. I don't know how often that occurs. I don't remember the statistics on that. But what are you looking for? And let's just say it's a child who was born, released from the hospital, but maybe born, plus 28, 29 weeks, but should be okay. But what are you looking for if things aren't going well?
The main thing that we're following, in the hospital, aside from, ultrasounds of the brain are the growth of the brain. And it should typically grow the baby's head circumference. We use tape measures and do the circumference of the baby's head, and it should grow about 0.5 to 1 centimeter per week.
Wow.
And it's impressive. And the fascinating thing about babies' heads, unlike an adult, our heads are fixed. And so if we get fluid and it can't drain, there's nothing to happen other than to cause pressure on our brain and have us stop
It's like
breathing,
a hemorrhagic stroke.
and stuff like that.
Yeah.
So it's just, whereas with babies, because their bones in their head are all separated by what are called sutures, and it allows the baby to be delivered through the vaginal canal because the head can be squeezed.
Mm-hmm.
Well, because of that, when the baby gets fluid that doesn't drain, the head will just grow abnormally. And the typical thing is a bulging of the fontanelle, which is French for window, basically. It's a diamond-shaped
That soft spot. We all kind of notice the baby's soft spot. Yeah.
Right, the diamond-shaped soft spot on the top of the head is called the anterior fontanelle. There's a smaller one called the posterior fontanelle in the back, but the main one is the anterior fontanelle, and so that will be potentially, it should be normally flat, but if it's bulging, and it will bulge if a baby's screaming and stuff like that because of just the pressure and everything, but if it's persistently bulging and the head is growing at an abnormal rate, then that's a significant concern for a parent.
And that's, and Dr. Velasquez, I know that probably is not something that presents until after birth. Yeah. When you are looking at a mom who is high risk at something, so we talked about diabetes, and I always like to touch base on diabetes here in El Paso. If a mother has gestational diabetes, what are some of the possible negative outcomes from that you are monitoring? So diet, but what is it that might lead to gestational diabetes may lead to what?
Okay, so first let me say that hydrocephalus can be diagnosed antenatally.
Oh, good.
And we try to diagnose it. Most of the time, it won't appear prior to 30 weeks. If it does, then it's a very accelerated process and it has a worse prognosis. So that's that. There are. It is more common in babies that have Down syndrome, and then there can be a familial component also.
Okay.
So that again, the
That's
history
good.
is
That clears
important.
that up. Yeah.
But the diabetes, it's important to differentiate between gestational diabetes, which is what you were asking, and type 1 and type 2. So type 1 and type 2 are the ones that lead to more complications because if it's poorly controlled, it increases the risk for anomalies associated to the diabetes.
Okay, so gestational, just so I have it clear and the audience have it clear, gestational diabetes only occurs when you're pregnant. It's diabetes that only shows up when you're pregnant. Is that correct?
And that's due to the insulin resistance created by the placenta.
Okay.
But type 1 and type 2, pre-existing condition.
Gotcha.
And if they don't control it before they get pregnant, they're more at risk for spine defects, cardiac defects, kidney abnormalities, and abnormalities of the lower extremities if it's extremely poorly controlled. They're also more at risk for a fetal demise, for losing the baby, and they're more at risk for losing the baby afterwards because the baby can develop a very thickened heart muscle that doesn't work very properly if the glucose is poorly controlled. So one important take-home message for diabetic mamas is don't lie. Don't lie when we ask you to bring your values because it'll show up either in the ultrasound or it'll show up once the baby delivers. So if you don't give us the values that are correct, we can't really treat the diabetes the way that we should, and the outcome for the baby will be worse.
Right. And there is, we talk about that quite a bit because people think, oh no, really doc, I'm eating well, I'm doing this, I'm doing that. So I appreciate that. I want to talk about, so there are 2 new level 4 designations at Hospitals of Providence at Memorial Campus. And I want to talk about that because I'd like to first define what levels mean, what some of these levels are. So level 4 designation, and I'm going to ask first for maternal care, and then I'm also going to ask for NICU, but how is that defined, and what is it that the hospital needs to do in that department to attain that certification?
So level 4 in a simple way means that we have the resources to treat any complication that arises from the mother or the baby.
Okay.
That we do not need to refer, and we have the teams in place that can take care of the mother and the baby. Whether it be imaging, whether it be radiology, whether it be the neonatologists, the surgeons, cardiologists, hematologists, intensivists, maternal fetal medicine specialists, everybody. So everybody that needs to be in place is there, and they're available 24 hours a day.
That's very important to say, 24 hours a day. So you've got the equipment there, you have the ability, at the end of the day, you have the ability to treat something that needs to be treated.
Yes, and we serve as a referral center for the other places that don't have those teams.
Okay. So here is probably an administrative question, probably goes with both of you. So when there is a hospital system that wants to have hospitals that are specializing in heart and brain, for example, or a hospital that specializes in mothers and babies, et cetera, is there like the team, if you have a El Paso, for example, and there's several hospitals to choose from here, when a team and administratively they choose, we want to be the hospital for A, B, and C. Is that a point where there's doctors and then there's specialists and researchers and the guys that say, okay, I'm going to go after this machine. We have to raise money for this particular piece of equipment. How does that work in your jobs as the doctors, right? You're like, oh, we're going to let somebody else do that. But obviously they need to come to you because it's like, what is it that you need, Dr. Velasquez, to do your job right?
Yes, so
how does that play into that?
We always ask for the best equipment because, we have to be better than the competition, honestly.
Right.
So we always want the most up-to-date equipment that's available. Either ultrasound-wise or ventilator-wise, medication, everything. So we can ask for it, and obviously it's up to the administrators to see whether it's in the budget or not. So they revise the budget every year.
Right. And the reason I like to bring that up too is that people think, oh my gosh, it was so expensive for this and so expensive for that. There's a reason for it, Toe. It's just, there needs to be money to buy the most updated equipment. And speaking of ventilator, when we're talking about lungs, that's one of the most important organ to have functioning if someone is born at 22, 23, 24 weeks. So you want to have that special ventilator. But take that same question and pass it through to the NICU unit.
So same sort of thing as like Dr. Velasquez had said, the level 4 designation for a neonatal intensive care unit is the highest level of care. In this case, it's a state level designation. So there's a state perinatal, neonatal, perinatal committee that sets standards for the different levels of neonatal and maternal care, and it requires a designation survey. So there's a survey team that comes that's outside of El Paso. They come from typically different centers throughout Texas, and they come for 2 full days, and they spend the time talking with me, reviewing charts, talking to the nurses, looking at minutes of our quality meetings, because we have to have, very detailed quality control on the things we do, our results with our babies that we get in various parameters. So it's very intense. And so in El Paso, the level 4, means we have every capability, with the exception of a pediatric cardiothoracic surgeon. So babies that have congenital heart defects that need surgery are need to either deliver outside of El Paso, or if we don't know about it in advance, then they deliver and then we transfer them to a center that has a pediatric cardiothoracic surgeon. So that's the only other things. The things that we are able to do are all different types of ventilation, what's called jet ventilation, high frequency oscillator ventilation.
Tell me what those are, if you don't mind, since you're naming them off.
So there's two forms of high frequency ventilation. One is a jet ventilator, and that is basically, it's a separate machine that's attached to the conventional ventilator, and it has what's called a flow interrupter. So it basically interrupts the flow of air very quickly. So you're talking like we breathe, as an adult, we breathe, I don't even know what a normal adult, because I know kids, but like 12 or 20 times a minute or something. Babies are typically 40 to 60 times per minute.
Goodness.
But the high frequency ventilator, we're talking 360 breaths per minute. So it's very, very small tidal volumes. And a tidal volume is how much air goes in with each breath. And the reason that that's important in the smallest babies is because you can get ventilator-induced lung injury. So we're trying to do everything we can to save the baby, but yet we end up causing damage to their lungs because of the ventilator that we need to use. But with the high-frequency ventilator, whether it's the oscillator or the jet, those breaths are tiny, but they're very frequent. And they're able to get down into the lungs, deliver the oxygen, get rid of the carbon dioxide, without having these big breaths that cause stretching and like scarring of the lungs, and it leads for a higher incidence of what we call in our world chronic lung disease, which most people think of as like an adult that smoked their whole life and stuff like that. But in babies, it's because their lungs were so premature, and we had to do what we had to do to get them to oxygen and get rid of their carbon dioxide, that they develop some, chronic lung changes that they may end up going home on some oxygen. But typically the nice thing about neonatology is most of these problems are short-lived, and they go on to lead a full, healthy, active, sports-filled life if that's what they choose.
I like you use sports-filled life. You can do anything.
Right.
I like that. Might there be, and this is always hard with almost any medical show, might there be a period of time where we feel like, okay, now neonatology is like at a forefront? And I say that because I always think back 100 years ago, we'd be in 1822 or 1922, I should say. And in 1922, I don't know what may have been around if a baby was premature or had some issues. So I always think that everything happened in the last century, but really all the magic has happened in the last 30, 20, 15 years. So in this space, and correct me if I'm wrong, because everybody's been having babies all their lives, it's just the way we populate. But in that space, knowing, for example, that these ventilators, yes, we're thinking just get the oxygen in them, but now you're looking at kind of divvying that up. When might have that been discovered by doctors? 20, 30, 40 years ago?
Right. So, it's interesting you mentioned like 1922, and I don't remember the exact year. I want to say like 1918 or something, but like
that's the Spanish
the interesting thing, right?
We've been hearing a lot about 1918.
The interesting thing is that they used to have at the World's Fair in New York, they had incubator babies, and you could actually, like, you were going to like the wax museum or something like that. You'd tour through and you'd see these little premature babies in incubators, and then they had like a iron lung type.
I remember that,
thing, but conventional ventilators that we know of like today. I've been doing this since 1986 or so, taking care of neonatal patients, premature babies. And so during that entire time, we've had, ventilators. There's been a lot of advancements in, like triggering of the ventilator, like trying to synchronize it with the baby. So instead of like the baby, initially we would just force a breath in. It didn't matter whether the baby was exhaling at the time or inhaling. it would be they're going to inhale because that's what the ventilator does. Now there's what are called flow sensors that actually can detect the baby taking a breath, and then it synchronizes the breaths we're giving with the baby's attempt to take a breath. So it just helps the baby take a breath as opposed to forcing against them trying to, instead of take a breath, trying to exhale.
Yeah, any way you can, just get that oxygen in. Right. Interesting. Dr. Velasquez, I'm curious. So once a baby is in the neonatal unit, and my next question to you, and if I forget, is that when is the preparation to where it's almost time to go home? So that's going to kind of be my next question. And prep of that, when you know of a mother that's going to have a baby that you know will be in the neonatal unit, what is the prep for that mentally? Like, is that something you do? Are there occupational therapists that kind of help out the family prior to that happening? And just explaining to them what to expect. Like, where does that fall? Does that fall on you? And how do you explain to families what's happening? And feel free to come in on this too, because I'm just thinking pre-baby, after baby, not after baby, but and I guess that's too.
That's where they consult us for what's called a prenatal consult.
So it just depends on the setting. If I identify a problem in the office, then I try to have them get an appointment with Dr. Welsh so that he can discuss what's going to happen once the baby is born and what problems does he anticipate, and does he anticipate any procedures? What does he think the prognosis is depending on the abnormality for the baby? Or if there's something that needs to be referred out also, does he want the baby even to deliver in El Paso, or does he think that the baby would be better off transported while the mama is still pregnant instead of waiting for the baby to be born?
Okay.
So that would be the ideal, to consult when she's still pregnant and stable. Sometimes we have to consult while she's in the hospital, and then it just depends who is involved and what the prognosis is for the baby. Right. If we think that the baby will not survive, then a lot of times we won't consult Dr. Welsh. We'll just consult the people that are involved with child life and with grieving, so that they can have the support psychologically. And of course, if they have a chaplain or a religious person that they would like to be involved, we can get them involved as well and make the family available to them for support depending on the situation.
So that is a very sad subject, but I'd like to expand a little bit on it, and maybe give some common reasons or issues why we know mom's got the baby, but chances are the baby's not. And I'm thinking at this point, it's beyond, and I'm going to use the everyday term of miscarriage. It's beyond the idea of a miscarriage, which usually happens relatively early on in the pregnancy. I always think first trimester. Sometimes it happens in the second trimester. But what are some of the issues where the baby will not be viable? We were talking about 22 weeks, obviously. But how would one know that the baby won't survive past 18 weeks or 20 weeks? Just some ideas or case studies that you may remember.
So, for example, anencephaly, where the baby has an exposed brain and most of the brain is eroded, doesn't develop.
Okay.
So they will typically survive, hours, maybe a few days. Severe, I don't know, I guess like high drops where there's fluid accumulation and the baby is in heart failure and it's gone beyond the point that they think that they can intervene.
Severe dwarfism.
That's not compatible. Or, for example, a trisomy 18, trisomy 13.
Tell me what that is.
Those are abnormal chromosomes, like Down syndrome has an extra chromosome 21, but Down syndrome babies, as you know, have a good prognosis for the most part. But trisomy 13 and 18 are life-limiting chromosomal disorders that tend to present with more severe abnormalities like of the brain, the heart, cleft lip and palate, abnormal limbs.
And I'm going to ask this question too. So in a pregnancy, is that something that you can see through an ultrasound? Is that something and I'm embarrassed, I haven't had a baby for 20 years, but 20 years ago, did I get a blood test every time I went to go see my OBGYN? I don't know. Did I? Maybe I did.
So there are screening tests,
Uh-huh.
and then there are diagnostic tests. So screening for chromosomal abnormalities would be doing a test that's called a non-invasive prenatal test that looks at the fetal cells in the maternal circulation, and that helps us identify the babies with trisomy 13, 18, and 21. And it
Okay.
also looks at the gender disorders, and that's done after 10 weeks of
After
gestation.
10 weeks, okay.
It also helps the moms have like a gender reveal party too, because
Correct.
they get
That's
to know
what they
the
use
sex.
So that's something you can see on an ultrasound that someone at 10 weeks would just naturally have anyway.
Not that
Is that what I'm understanding, or no?
No, so
No, okay.
the blood test we can do at 10 weeks.
Okay,
And then the nuchal translucency we can do by ultrasound at about 11 and a half to 13 and a half weeks. And that's where we measure the little space, kind of the equivalent of the neck when the baby's older. That gives us an idea if the baby's more at risk for Down syndrome, for heart defects, for dwarfisms, metabolic disorders.
okay.
But not everyone gets prenatal care
That's
early.
kind of my point. Yeah, so I'm wondering if there are some moms that just have no idea.
Yes. So
that there's an
then,
issue.
yes. And then we do the anatomy scan between 18 and 20 weeks. And that's when we look at the whole fetus, do a survey in the anatomy. And that's typically where we identify abnormalities. And if the mother decides that she wants diagnostic testing, we do the amniocentesis, where we take some amniotic fluid that has baby cells. They grow them in the lab and culture, and then they look at the chromosomes and identify the problem
Okay.
at that point.
Okay, and that's kind of where I was going, is if you think you're going to have a normal pregnancy, you think everything's going along well, how and when, because I want to say I had 2 ultrasounds with my first little one, and because I lost a baby in between, I felt like I had quite a few more with the second one. I had my first baby at the age of 30, my second baby at the age of 35. I don't know if that mattered or not, but again, it's one of those things that now that we're talking about it, you can only go back to your own experience of what that was, and I just kind of wonder sometimes.
Yes, and most mamas, you're right, still only get 2 ultrasounds. But that's the only plus side to being high risk, because then they get an ultrasound every visit, because we have things to follow, the baby's growth, the baby's well-being, and
Right.
we can identify problems.
That makes perfect sense. Makes perfect sense. Okay, what was the question I was going to ask you? Did you remember your homework?
When the baby's ready to go home.
When is the baby ready to go home? And that's and I know it's different because you have the 22-week-old, and then you've got someone that was, what was the statistics? If they're born at 27 weeks, again, only 5 weeks more. It's 57% survival rate at 22 weeks, and at 27 weeks, it's 96% survival rate. And I guess my question there is too, if there's a gestational time frame when they were born and then their expected birth date, does that factor into it all? Is it time, or is it really how the baby is performing, or both?
We tell every parent of a premature baby that, think in your head your due date.
Okay.
So, if you're 22 weeks, your due date is 4 months down the road, 4 or 5 months down the road. And the other factor is that the more premature you are, the more likely it's going to be either at or maybe a little bit past your due date.
Okay.
But we tell every parent that as soon as your baby's doing everything they need to do to go home, which is the same for every baby in the NICU, is basically they have to be, unless they're going to go home on oxygen, but aside from that, they have to be breathing room air with no respiratory support for at least 24 hours, so off all respiratory support for 24 hours. They have to be feeding on their own, gaining weight, and not having any what we call apnea of prematurity or forgetting to breathe spells. So premature babies have their brainstem where the breathing center is, and that's the center that makes it so that you can't hold your breath forever because your carbon dioxide level builds up and it forces you to breathe.
Right.
And so the babies, those neural connections are not very well developed, so those babies will get apnea of prematurity, well, they'll just stop breathing. And so they have to have a period of time where they're free, typically 5 to 7 days, without any apnea, bradycardia, or desaturation sort of events. And then they go home. Now, there's babies, like I said, that sometimes they get to full term. We can't get them off oxygen, but they're only requiring a little bit of oxygen, then they'll go home on some oxygen. And the same with feedings. There's some babies that, for such a long period of time, because of how sick they were, they never could either breast or bottle feed. So they all got tube feedings for so
the
long.
swallowing?
So it's a suck-swallow sort
Okay.
of thing.
Right.
So that takes a while sometimes to develop. So we'll have some babies that have to get supplemental feeding even after they go home. We try and get them to the point where they're nippling everything on their own or going to breast and feeding on their own before they go home. But a small percent end up going home either with a feeding tube or a G tube, which is just a little button on their belly where they can hook up some feeds, and whatever the baby is not able to take by the bottle, they can supplement that way. So, but yeah, so the main thing is that, we just tell them, because that's the bane of our existence, is when we get close to discharge, but they're still not finishing their feeds, or they're
Right.
having a forgetting to breathe spell or something like that. And the parents just want to take their babies home. And they're so frustrated. And we're saying, we know, we understand, but remember what I told you back at 22, 23 weeks that, your due date's still a week away, or we're not there yet. So, and it could take even longer. So,
And then the training process, I'm curious about that too, because you're looking at training non-medical people. So mom and dad may not be in the medical field.
Right.
And the training there, how does that, who does that? How does that work? Is there, I'm assuming a special team that kind of helps out with that too?
correct. I mean, so we have all those therapists that, so the speech therapists and the occupational therapists work on feeding. Physical therapists typically works on muscle development and movement and correct positioning of the baby and preventing the baby from getting what we call plagiocephaly, which is if they're lying flat on their head for a long period of time, they can get kind of a
Right.
narrow sort of head shape. And so you have all these people, and it's amazing because the parents that have been there for so long, in some cases 5-6 months, they become very adept at everything. They know their baby better than, because they're there every day, they're doing everything, they see what the nurses are doing. So they become very educated on taking care of babies. And it's interesting because we've had, in fact, one of my neonatal nurse practitioners, became a neonatal nurse practitioner because he had a very premature baby.
Right.
And we've had mothers the same way. They become neonatal nurses because of everything they saw that the nurses did for their baby.
Became a calling for
Right.
them. Yeah, the gentleman that I was speaking to today said the exact same thing. He said, he actually wanted me to touch base on that, that what are the parents, and that's why I kind of asked that question too, what is the role of the parents, both mom and dad, while the baby is in NICU? The skin-to-skin touch is so important, et cetera, et cetera. And so I know we're at like 10 minutes before the show's wrapping up, so I usually like to take this time and ask my questions, but see if Dr. Velasquez, if there's something that we have not yet covered this evening that you'd really like to get out there and cover, and same thing, because I think sometimes we can get bogged down on questions, but you came driving thinking, oh, I just really wanted to make sure I said this and this and this. And so many years ago, I thought, okay, stop the show at 10 and it's your show. Is there anything that you'd like to talk about that we haven't covered yet or expand on?
I think that part of the problem with high risk is identifying the problem. And unfortunately, there is still not very good access to prenatal care. And people don't get in early enough to where we can identify the issues in time to intervene, or they come in already far along in their pregnancy and we know that the baby's not going to have a good outcome. So I think that access to prenatal care as soon as you know that you're pregnant would be the best option if possible. Unfortunately, because we have a high Medicaid population, just the the ability to obtain medical coverage is very crazy, you know?
Right,
So
right.
it's not always possible, but if at all possible, the earlier that we can see you, the better, so that we can put things in place to have the best prognosis for the pregnancy.
And if we have somebody listening that may know someone who's pregnant, what are some of the things that you can say just now, you know, vitamins, et cetera, exercise? What is it that you can say right now if they're not able to get care that they should via a doctor? Are there some options that you can give them, some advice?
So I think for all women of childbearing age, you know, folic acid is very important. So if you can just stay on a multivitamin, even whether you're planning or not planning a pregnancy, so you can decrease your risk for having a baby with a neural tube defect, a defect of the spine, that would be
So folic
great.
acid is specific for spine issues?
Correct.
Okay.
If you can maintain a normal body weight, that would be great. And then take control of all your medical problems before you get pregnant. So make sure that your diabetes is well controlled, make sure your hypertension is well controlled, make sure that if your thyroid is needing to be replaced, supplemented, make sure that that is replaced appropriately, because otherwise the babies are at risk for mental delay if the mama just stops her medications and the thyroid levels are very low, because the baby doesn't make the thyroid hormone until 13 weeks.
Oh,
So
until 13 weeks.
So
I
those-
found out I had hypothyroidism while I was pregnant. I had no idea. I didn't even really know what it was. And so that's interesting. And I'm still on Synthroid all these years later. But I didn't realize what the outcome would be if I didn't go on medications. I thought to myself at the time, I want to be really good and not take anything I don't have to take. And I thought, why am I going to take an extra hormone? I've got all these hormones anyway. But a thyroid hormone, on that note, can you explain what a thyroid hormone is, different from like the female hormones? Because thyroid, men, women have thyroid issues too.
So
Okay,
a
expand just a
hormone is
smidge on that.
just usually a protein that is created by, or a steroid hormone that's created by a glandular tissue. So you have the thyroid, you have the adrenal glands, you have the ovaries. So something that produces a substance that will make the body produce something else or act in a different way.
Okay.
So it's all part of the endocrine system.
I like how you said that. It makes the body act a different way than it should be acting. That's a very nice way to explain
Or
it.
the way it should be.
Yeah, there you go. Dr. Welsh, anything that you would like to get across this evening? And we still have some stuff that we can wrap up with, but I just wanted to make sure.
You touched base on one of the things. What can the parents do, or what while they're there? And after a mom delivers and their baby's in the neonatal intensive care, I try to go up and talk to them in labor and delivery or in recovery room, and just let them know that okay, your baby's in the NICU, is doing well, the vital signs are stable, this is what's going on. And the most important thing that you can do during this time your baby is in the NICU is be there in the NICU when you can for your baby. The next most important thing, and probably as important, is pumping breast milk for us.
We haven't touched base on that. I'm
And
glad you said that.
That's critical, especially in the preterm babies, because breast milk is the safest for the babies. It's the best for them. And we have a very good donor breast milk program system where we get our donor milk from the Austin Milk Bank that serves pretty much all of Texas, and I think even outside of Texas, where moms go in and donate. They're tested. It's just like donating blood. They're tested for infectious disease. The milk is pasteurized and processed and everything. And
That's
we
something
use
we
that.
never hear about. So I'm really happy that you're bringing that up. Every now and again, if you're in this situation, you'll hear about it, obviously. But other than that, you really don't.
Right. So it's second best to your own milk, because your own milk is specific for your baby. It has all the antibodies, and a lot of the processing that we have to do to the donor milk to make it safe takes away some of those benefits of breast milk. but it's still superior to any formula that we have as far as safety for the baby. Because I told you with premature babies, their intestine is one of the systems that can be affected and by the prematurity, and they can get a condition called necrotizing enterocolitis, which has a very high mortality rate, one of the common reasons where a very premature baby can die from that condition. And we know that using exclusive breast milk diets significantly reduces the risk of necrotizing enterocolitis. So I tell the parents that, and I said, even if you had no thought in your mind you were going to breastfeed when you go home, or I don't care about that. What I do care about is that during this time you pump for us and you give me your milk.
Right.
And I'll give your baby donor milk until your milk comes in, and it may take 2, 3, 4, 5 days or whatnot, but we have that bridge available to kind of get you through that. And, and the interesting thing about parents visiting, so there's been this movement in the past probably 20 years now of towards private NICU rooms. It used to always be an open bay, and there'd be baby, and a little chair for the mom and the dad, and they're tucked in a corner, and they put a curtain up. And well, now the newest units, most of them are moving towards private rooms. But the interesting thing is that the research has shown that private rooms are better for neurodevelopmental outcome only if the parents are actually there.
That makes sense to me. Of course.
And they're actually worse if the parents don't show up, because there's nobody in the room providing that stimulation. So they're better off being in a large, open bay if there's no parents around, because that stimulation that the parent provides with the skin to skin, or talking to their baby, playing music, similar music that maybe they played when they were pregnant.
We're pack animals. We need each other. I'd love for you to really quickly touch base on, because you said you had a meeting today. It was kind of a construction meeting, but there is going to be a new NICU unit at Memorial, and I know we don't have a lot of time, but I just want that to be something to talk about. And are we looking at privatizing rooms in that?
Correct. So the current NICU at Providence Memorial Hospital is an old style 1970s era open bay with lots of babies, very little room, and so it's been desired for quite a while now, and it's never kind of like gotten over the inertia needed, both from a financial standpoint and whatnot at a hospital level.
I love that. Dr. Velasquez, thank you so much for being here. And Dr. Welsh, thank you so much for being here. I learned a lot. I always learn a whole bunch. And I always like to leave everyone with the question, like, what's next? And I know there's great things that both of you all have been doing this entire time. So Tenet and Hospitals of Providence, they're the ones that underwrote today. And also I want to say again, another thank you to the El Paso County Medical Society. They've been hanging in there for 25 years, bringing this show to you. And if you didn't catch all of this program, you can always find pbs.org. You can go on there and go to watch and then find the El Paso Physician. And you can also go to the El Paso County Medical Society website. That's I always get epcms.com. And then also if you look up the El Paso Physician, use the word the El Paso Physician on YouTube, you can also find this program once again as well. Thank you so much for watching. I'm Catherine Berg, and this has been the El Paso Physician.